My name is Subbe. I'm a consultant physician and senior clinical lecturer at Bangor University. As part of my Improvement Science Fellowship, I examined opportunities for a more active role of patients in their own safety during acute illness. Safety is one of 6 domains of quality and arguably of particular relevance during acute illness and hospital admission. But despite 20 years of attempts to improve safety in hospital, the National Reporting and Learning System shows little evidence that safety has actually improved. At the same time, there's an increasing body of anecdotal evidence that if something is about to go badly wrong, patients and those close to them often have got an inkling that that's about to happen well before their doctors and nurses are realizing this. We've used these insights as a starting point to explore how safety in hospital could be improved with and by patients. There are some conceptual arguments for this. The first one is that modern healthcare is increasingly fragmented, and therefore the patient is often the only person who really knows the whole journey. Safety is often measured by deviation from normality, but in somebody with chronic illness or frailty, only the patient and those close to them will be able to define what is normal. And last, you can probably not argue with the fact that the patient is probably the person who cares most about their own safety and therefore might have a good position to action on safety. As part of the fellowship, we collated a number of case studies in this report with the Bevan Commission, starting for roles of patients in investigation of their own safety as part of the Health Service Investigation Branch and looking at management of complex medications in self-management programs. We then looked how those type of principles could be scaled up in a digital healthcare system, but we found little evidence from scoping reviews of electronic health records that safety events had been significantly affected beyond maybe medication safety, and we found no evidence for personal health records. In order to create interventional studies, we used a framework for co-production of prototypes called BASE. In this framework, the patient and the ecosystem is supported by 4 kinds of knowledge. Knowledge about science, engineering, business, art and design, creating the evidence base, feasibility, viability, and desirability of new interventions. We applied this framework to generate 2 interventional studies. In an express check-in, we created an opportunity for patients to document their own records when they were admitted to hospital as emergencies, and we were able to show that their ideas, concerns, and expectations added significant information to that was recorded by doctors and nurses. In the Keep Me Safe study, we created a smartphone application with checklists for side effects of powerful treatments for cancer. In the controlled study, we were able to show that this approach is feasible, it's sustainable, it's well liked by those using the application, and it is safe. So what have we learned? We've discovered opportunities for acutely unwell patients to generate and use safety critical information with the potential to take a more active role in their own safety. Arguably, this role of patients is enhanced by support from their own social network. Does this matter? To patients, absolutely. Does it matter for safety outcomes? This will require bigger studies. I wanted to use the opportunity for a big thank you to all those that have contributed to this program, and maybe invite you to the 3rd symposium on patient-powered safety on the 20th of May 2021.